Okay, good morning, everyone. Thank you for joining this morning. My name is Minji Kang, and I am a project manager for cultural competency and health literacy in Albany Medical Center Hospital, PPS. We would like to welcome you to today's training webinar on the introduction to cultural competency and health literacy. Before I introduce Wilma, I'll mention a few housekeeping items first. Please note that your lines are all muted to reduce any background noises during this webinar. So if you have any questions, please utilize the chat box, and we'll have a Q&A session at the end to answer all of your questions. And also, please remember to email the district email to confirm your participation today. As you know, your participation fulfills one of our contract metrics, IDSE2. So, and for us to report to the DOH about this training activity, we're going to need your organization name as well as attendee names, their job titles, and their email addresses. After this webinar, all participants will receive a link to complete the post-training assessment and a course evaluation. We would really appreciate if you could please take a moment to answer these questions so that we can improve our future training. And again, please remember, email your organization name, attendee names, their job titles, and their email addresses to district@mail.amc.edu. And lastly, I would like to let everyone know that we are recording this webinar. So now I would like to introduce our speaker today, Wilma Alvarado-Little. Wilma Alvarado-Little is the principal and founder of Alvarado-Little Consulting, which focuses on health equity issues from a linguistic and cultural perspective. In addition to her interest in public policy, health literacy, and health disparities prevention, she has been instrumental in the development and implementation of hospital and clinic-based programs, and she is a healthcare interpreter and trainer with over 30 years of experience in healthcare field. She is a former co-chair of the Board of National Council on Interpreting in Healthcare. She is a member of the National Project Advisor Committee for the Review of the Class Standards, HHS Office of Minority Health, the National Academy of Sciences, Engineering, and Medicine Roundtable on Health Literacy, and the chair of the New York State Office of Mental Health Multicultural Advisory Committee, and she also serves on boards at the state and local levels, which address multicultural issues. She has a Master of Arts degree in Spanish Literature and Master's in Social Welfare. Currently residing in New York, Wilma dedicates her time to issues involving the provision of linguistically and culturally appropriate health services nationwide. So we really appreciate Wilma for being here today, and I'll turn it over to you, Wilma.
All right, well, thank you, Minji, for that very generous introduction. And this is so exciting. We've been looking forward to doing this, and so I will go through. I understand that we have a limited amount of time to talk about an issue that, as you know, is very complex. And so we'll get started, and my understanding is that there'll be opportunity to ask questions at the end of the session. All right. So what we're going to be doing is just quickly going over the introduction. We'll be talking about the expectations for this participation and also an overview of cultural competency, language access, and health literacy. Also, we'd like to learn about where are we as an organization regarding the areas of cultural competence and health literacy and language access, and what are going to be some of the next steps regarding the strategy that has been presented by the Albany Med Center PPS. And then we'll have some questions as well. All right. So the first thing, because one of the things that happens when we're doing some of this work via webinar is the temptation to multitask. So I'm just going to put that out there. And so for this, what I'd like you to do is just look at this image in front of you, and it asks, can you connect the dots? And I'm going to ask folks not to look at other possible resources that might lend a solution, but look at the dots and think, okay, how can you connect these dots without lifting your pencil and only using 4 lines, okay? It can be done, so I'm just going to pause for about maybe 5 seconds, and then we'll resume from there. Okay. So if we were doing this, for example, in person, what we would do is we would have more of a hands-on activity so that folks would be able to work through this process. and also to perhaps some partnering with somebody who would be sitting next to you. In the absence of that, I'm going to walk you through how we can connect these dots, all right? So we ask ourselves, how do we connect the dots, if you will, when we're working with our communities? So the first connection might be cultural competency, and you already see that we've gone past the third dot on the lower left side, right? We're not staying within the grid that's being presented to us. The second dot to connect might be one of language access, and again you see that we only connected 2 dots so that we can reach our goal of using 4 lines, yes? And we can liken our goal of using 4 lines to supporting well-being and healthy outcomes with the services that we will be providing through this initiative, right? So here's the third line. We might liken this to that of health literacy. So with these 3 lines, we've gone and we've already accomplished the connection of cultural competency, language access, and health literacy. And the 4th line, here we've gone ahead, completed our goal of using only 4 lines without lifting our pencil. And if we continue to use the parallel of our services and the provision of them being culturally and linguistically appropriate, we've accomplished some of our objectives, or the beginning of accomplishing of our objectives for those whom we serve, right? So one of my favorite quotes is from Anais Nin, the poet. We don't see things as they are, we see things as we are. And that's a very human thing to do, because we are made up of our experiences. And so when we encounter a situation that might be new to us, what is very natural in human nature to do is to file through our experiences and see what we can do to resolve what we are not understanding. And so we can go ahead and talk about, in another opportunity, that of implicit bias, unconscious bias, and perhaps even microaggressions. What we're trying to do is fill in the gaps with our stories and our experiences. Are they sometimes accurate? Are they sometimes not accurate? This is where the role of cultural competency and health literacy, especially in healthcare, becomes really, really important. So our objectives are going to include discussing cultural competency and health linguistic barriers to accessing healthcare, developing an awareness of federal, state, and local mandates. And this second objective is one that can be a whole other discussion in and of itself. And so we'll give you a very brief overview of the mandates. And then also to providing some resources regarding the provision of quality services to address the barriers that contribute to health disparities within our communities. And so one of the documents we'll be talking about will be the class standards and also the 10 attributes of a health literate organization. Okay. So one of the other items we want to talk about are the CCHL Champions. And, you know, this has been something that we've discussed earlier, and so just want to make sure that we have a reminder to you, because the champion role is just so incredibly crucial and important in this process. These are the folks that will be working intimately with the work group here, and also will be having the information to disseminate amongst the organizations as well. So if we're going to be able to begin to weave these concepts throughout our practice, this is something that we'll be able, this is something and someone that will be able to help move things forward. Okay. So for, in order to provide patient-centered care, and when we talk about our projects, you know, the communication is key to addressing issues that are contributing to health disparities. And so also when we don't speak the language of that patient, we have to use an additional set of skills to continue to provide excellent care. And when we talk about speaking the language, it's not talking about something that is geographically grounded. So for example, we're not just talking about Spanish or Hindi or Punjabi or Karen or Kareni. We're talking about speaking the language of, say, for example, adolescents, terminology and vocabulary that might be used in an rural versus an urban environment. So the language piece has a much broader scope, right? So this is a definition that is being used within the strategy, the ability of providers and organizations to effectively deliver the healthcare services that meet the social, cultural, and linguistic needs of patients. And when we think about cultural competency, we remember that they go beyond that of race, ethnicity, and language, right? So we're talking about the culture of health and medicine. What does that mean to those who are not healthcare professionals? What does that mean to the end user? What does that mean to the healthcare professional when he or she becomes a patient, right? These are different things. What is recreation? We talk about safe spaces within an urban community, such as parks and other common shared spaces. Are our parks safe, or are they places where they might be a bit problematic, right? We talk about the urban versus the rural cultures, and what are the definitions? So even thinking about transportation, what does that mean within the rural community, and what does that mean within the urban community, and what's the definition of urban? So for example, somebody in New York City living within the 5 boroughs might think Albany is not as urban. But if we speak to somebody who might be in a rural area, for example, farther upstate New York, Albany is quite the urban area. What are the values and manners of interacting, too, within different cultures and also within the different environments? What's the workplace culture, right? Is it one that's more open, set up in cubicles, or is it more so office? Are there certain quote-unquote rules that are to be followed, whether they be written or unwritten? What's the concept of time? This is huge when it comes to healthcare, because some of our countries don't have an appointment system. You show up early, and whomever shows up the earliest is guaranteed to be taken care of sooner. And does this really work within some of the models of the provision of healthcare services within the communities we're working with? Our adolescents have their own culture, our elder community as well, and how are we going to interact with one community versus the other, yes? Language, again, as we mentioned earlier, what are our ethics in these different cultures? And grooming and presence as well. What are some of the behaviors that are expected? So for example, for some exams, for example, a mammogram, there's certain practices that are requested of a patient, for example, not using any deodorant. So how is this going to be interpreted by individuals if this is their practice or if it isn't, right? And then the issues of transportation. When appointments are set early in the morning, is there an understanding that that individual is going to be able to access reliable transportation in order to meet that appointment time, or if that individual runs late because of the lack of secure transportation, is that individual going to be perceived as being non-compliant, right? And then significant events. What are some of the significant events of those whom we serve and also our own that fall into the cultural perspective? So within, for example, the Latina community, the quinceañera turning 15 is a significant event, whereas the Sweet 16 is a significant event as well. When I was doing a similar talk, I'm giving a similar talk in an area closer to New York City, and I asked about significant events. One of the comments that were presented was that of 9/11. And so one of the participants who staff at one of the clinics, she said, well, every morning I wake up and I put on shoes that I know I can walk home in. Now, this is 10 years after the event, but this is something that she keeps in mind to this day. She's going to wear a pair of shoes that she knows that can get her home from Manhattan to Brooklyn, right? So we talk about this cultural iceberg, right? And so when we look at this top 10%, This is what is easy to see. When we see our patients or our clients who walk in through the door, this is what is visible. We see an overview, we see something physical. If we start to engage with them, we begin to hear and see a little bit more, but this is the 10%. We only see a glimpse of our clients' lives. We don't see that other 90% right off the bat when they walk through our doors. So what are their values? What are their priorities? What assumptions are we making? What has been happening in their lives before they walk in the door, before we begin to engage with them? What has been going on that we're not aware of that might be contributing to a current healthcare situation or a past healthcare situation that is still top of mind for them? And then what's next? What's next for them? When they leave our offices or our services, what are the thoughts? What do they have some questions that for whatever that top 10%, the customs we might be aware of, might not be aware of, that they still have in mind that they haven't shared with us yet? And we think, okay, fine, you know, we've been able to fulfill a need for them. Fingers crossed, hope all goes well as they walk out the door, right? So this is that 10% that we're aware of. The work where we need to be more culturally competent and aware of our health literacy and language access is that remaining 90%, right? So we've talked about some of the projects that are happening within the PPS. So as we talk about the different pieces here, we are looking at better care and less cost. And what exactly does this mean to those whom we serve? We know what we're trying to accomplish on this end, but to that individual who is coming in, for example, for behavioral health, is this going to resonate with them? Or are they thinking more of the cultural, competent, and health literate perspective? Behavioral health leads to mental health, which leads to mental illness. In some of our communities, this is not to be discussed, as the experts dealing with behavioral health are very aware. So if that's being discussed, then it doesn't exist, so problem solved. But what are the cultural, competent, and health literacy pieces to this? And when we're talking about health literacy initiatives, what are we going to keep in mind as we try to move this piece forward as well? We had been working with one of the communities who, and one of the things that they said was, we really wish when they tell us about a medication, they would just tell us exactly how they want us to take it, because it's vague for us to say to take it in the morning, take it in the afternoon, and take it in the evening. When you work an evening shift, 11P to 7A, that morning might be a little bit different. So how are these pieces really going to be health literate when it comes to something as what we might consider basic as taking a medication as prescribed? And the other piece too is, say, for example, some of the religious holidays that require fasting. Some of our communities, if they are prescribed a med during the time when they are supposed to be fasting, chances are that they will adhere to their spiritual requests as opposed to a healthcare one. So these are some of the things that we should consider as well, right? So there had also been a survey done amongst the PPS partners. We'll look at this data very, very briefly, as my sense is that this has been shared with the UN, is also accessible as well. So when we look at organizations that are responding to appropriate language services, 85% responded that they do. Yes, that they do. When we tease out the data a little bit more, we look at 53% that use certified or trained medical interpreters to provide interpreting services. So the question is, certified by whom? Yes? And how is that awareness being communicated throughout the staff? And trained medical interpreters as well. And again, this is a discussion for another time to talk about certification and talking about training. We'll touch on this a little bit more as well, but we also wanted to make sure that this information is presented to you folks during this time. And then 42% said that they conducted staff training on the use of interpreters. You know, we also need to consider that we might also have per diem staff. We also might have turnover. So when are the staff being trained on how to utilize interpreters? And then also, what are the provision on how to access interpreters as well, right? So there seems to be more of a use for sign language interpreters as opposed to spoken language. And so this is something, an area to think about as well when we're talking about the cultural and linguistic appropriateness of the provision of services. And then 38% said that they had a policy that minimizes the use of family members as interpreters. So we're going to talk a little bit about language access because, you know, we have quite a bit to cover, but I just wanted to make sure that we put out these points. That the state of New York does have some mandates regarding the provision of language access services, and New York State is one of the few states in the U.S. that uses the vocabulary of minors. So in the state of New York, a minor is considered somebody who is 16 years of age and under, who in the healthcare situation is not to be utilized as an interpreter unless it's emergent. Now, the word minor is used instead of child, and when we think of a 14-year-old, we might not think of them as a child, so they might be put in a position potentially to be utilized as an interpreter. But when we use the word minor, that gives it a different lens to the interpretation of this New York State code. And then Governor Cuomo had also authorized New York State Executive Order number 26, which requires the provision of language access services to any organization that is receiving state funding. So if clients are being referred over to WIC, then that is an organization that is required to provide language access services as well, right? So just a really quick moment about the difference between being bilingual versus interpreting versus translation. So bilingual is somebody who professes to speak two languages. So this could be somebody who has taken or studied a language in school at some point, and their language skills have not been assessed, yes? So this could be the patient in the next bed. It could be somebody who has an interest in languages. However, does their language skill hold up in a court of law? Because remember, interpreters, just like anybody else, can be subpoenaed. And then interpreting is the oral communication and translation is the written communication. And so many times the media uses these terms interchangeably, and it is just really very, very frustrating to continue to disperse the misinformation. These are two different skill sets, and at times they fall under different mandates. So for example, New York State is one of the states in the U.S. that reimburses interpreting services. They reimburse interpreting services in certain situations. At this time, it is my understanding that they do not reimburse translation services. So for example, if somebody were to have a document converted from one language into another and would submit a request for reimbursement, that would not be reimbursed. So important to keep these two pieces separate. Sometimes I hear simultaneous translation. Now, simultaneous interpreting is when it's the UN model. So as somebody is speaking, we're interpreting. And we usually use this in very high-stress situations when either the provider or the patient is speaking very, very quickly, and we are not in a position to interrupt because it would really, really negatively impact the relationship between patient and provider. So we as interpreters will go into simultaneous interpreting. I have heard the term simultaneous translation being used. So this is what that means, because remember, translation is the written communication. So this is basically being ambidextrous, right? And then here is somebody doing simultaneous translation, I guess. And remember, never use a minor, okay? All right, so that was our little discussion on language access, right? So this is more information regarding the PPS partner surveys. Some folks have funds allocated for cultural competence activities and initiatives. Others have activities within their organization for promotion of this regarding culturally diverse workforce. And again, remembering that culturally diverse is not limited to race, ethnicity, and language. And then 21 responded that their organization requires or facilitates individual provider assessments regarding cultural competence. And the 63% of the organizations also have some type of policy involved regarding representation or from populations and communities served. So what we have to ask ourselves is, well, where are we, right? Where are we regarding all of this? And so if we use this model that is influenced by Terry Cross, and this comes from the National Center for Cultural Competence, we're looking at the continuum, yes, because we are always learning. When we are looking at issues of cultural competence, health literacy, and language access, we are always learning, yes? So according to Terry Cross's model, the first layer would be cultural destructiveness. So this would mean more so attitudes, policies, and practices within the organization that are destructive to cultural and individual members that are part of that culture. And I'll share a story with you so that we can and then we refer back to this continuum. So say, for example, a healthcare organization is asked about what their language service and cultural competency resources and provision to the community are. And the organization responds by saying, well, all of our patients speak English. And say, for example, if this were a hospital-based organization and they were licensed for more than 500 beds, that would be really interesting that everybody who walks through their doors speaks English, and speaks English to a level that can communicate with a physician during, morning rounds, that can communicate during an outpatient clinic visit regarding meds, if this person were a diabetic or a smoker. And so pressing on that, what would this organization say if they were asked, this is a large facility and all of your patients speak English? Say, for example, their response would be, well, sometimes we do use the interpreter on the phone. Okay. So if we're talking about cultural incapacity, the organization doesn't intend to be destructive, but they lack the capacity to help minority clients and their communities, or communities where the population is being generalized. So it's not being done with malice intended. It's just that the organization is not at that point of addressing this issue. They just don't have that capacity right now. Cultural blindness is that the organization functions with the belief that the individuals of color or culture, it makes no difference, and that all people are the same all the time. So going back to the analogy of somebody saying, well, we do use the phone when it's for interpreters, that blindness where they think that service applies to everybody, a telephonic interpreter would not help a deaf patient or somebody who's hard of hearing, yes? So using one system to try to address all these other issues is not going to be really helpful. So there's a limitation there, that there's an awareness of something, but there is still a limitation. The precompetence is that the organization recognizes that there are some challenges, they do have some weaknesses, and they're attempting to improve some aspect of that service to either a specific population or their population in general, right? So now it's like, okay, we are noticing something. We are seeing trends that certain communities on certain days are showing up late, or their medication adherence is not working, or something is not supporting that well-being and that healthy outcome that we're anticipating. So what do we need to do to make that better? Yeah. So this is the area of cultural precompetence. And sometimes, all these pieces are moving, yes? It's not the same for the organization across the organization. This is not linear. this is fluctuating within the different areas of the organization, whether or not sometimes, you know, the organization is aware of it. And so this is one of the things we need to look at, right? So then cultural competence is that the organization is characterized by acceptance and respect for differences, continuous expansion of cultural knowledge, and a variety of service models to meet the needs of the various communities, yes? So now the organization is saying, you know what, we tried this in this situation, we tried this in this situation, we're looking for feedback from the community, and the community can be the providers, it can be the patients, whomever else is involved in this equation. So this is the area of cultural competence that we're striving for, yes? And that's why the evaluation is so important, because if we implement something that's great, however, how is this really working? And then the cultural proficiency is that the organization is seeking to develop a base of knowledge of culturally competent services by conducting the research, developing new therapeutic approaches based on culture, publishing and disseminating information on cultural competence, and then also hiring specialists in culturally competent practices. So we are not, in that last statement, hiring specialists in culturally competent practices, we are not looking for someone to say, for example, and I'll use my background, oh, we need to work with the Latino community, so let's see what Latinos, what resonates with them. Within the Spanish-speaking community, there is a lot of diversity as well. And we also, whenever we're looking at any of the communities, like when somebody would ask me, you know, about a Chinese interpreter, I would say, well, which language? Because are we talking Cantonese, Toisanese, Mandarin, Taiwanese? We should be aware as well of the possibility of stereotyping. So needing to keep all of these variables in mind, and so that we are always thinking outside of that box. So this is a mnemonic that comes from HRSA, and the citation and the reference is here, because it's great if the organization is looking at these things, but what about the individuals that make up that organization, yes? So these are some of the 5 elements that we can also keep in mind when we look at ourselves, right, at the individual level. So awareness, are we aware of our personal biases and prejudices towards certain cultural groups that are different than mine? So for example, is somebody who has been, for example, in the healthcare field for many, many years, having difficulty or sometimes thinks, okay, my next patient is a single young mom of color, yes? Is this going to already fill in certain biases that based on what they might have experienced working with somebody in a similar population of that group, right? So thinking about that and stepping outside of ourselves. So do we have that awareness? Because it's always good to step outside of oneself to see what others might be seeing, or at least have a sense of what others might be seeing about our own practices. And then the skill, do I have the skill to conduct a cultural assessment in a culturally sensitive manner? How are we going to talk about this in some of the areas that might, as I mentioned earlier, might be considered taboo? Do we have those skills and those resources to present a question? As a healthcare interpreter, one of the questions where providers will look at me and ask, I have these materials in Spanish, does this patient read in Spanish? Well, because somebody doesn't speak English to the level that is needed in a healthcare environment doesn't mean that, for example, that's true in their own language. So sometimes a Spanish speaker, yes, they can read in Spanish. That's not a problem. Sometimes there might be certain cues to the provider that there might be some challenges with reading materials. However, how is that question presented in a way that is sensitive without saying, how literate are you in Spanish? That might be a bit much. However, presenting it in a different way, such as we have these materials in Spanish and English, which one might be easier for you to read? or is there a family member that might be able to read this for you if you have any questions? So navigating this is something that to consider as well. And the knowledge, do I have the knowledge of the client's worldview? So again, talking about issues of transportation, talking about religious and dietary restrictions, keeping these things in mind when we're working with that individual. And of course, it's impossible to know every nuance of every culture, of every patient, and of those whom we serve. So being able to have that awareness and that ability to be able to present questions is going to be key. And then encounters, how many face-to-face and other encounters have I had with clients from diverse cultural backgrounds? And also, too, what is the definition of diverse? Yes. Is it somebody who's from a rural community and we're from an urban community, or vice versa? Is it somebody who may have an adult illiteracy issue and we're not aware of that? So keeping in mind what is that diverse cultural background and what does that mean to us? Again, having that awareness, stepping outside of ourselves. And again, remembering that when we are serving someone, we're looking at that top 10% of that iceberg, yes. We don't know what that other 90% is going on. So how do we know what that diversity means when we are encountering somebody? And then desire, do I really want to be culturally competent? And I leave that up to, you know, the individual to answer that question. So we're looking at things from an organizational perspective, and we also have to look at it from an individual perspective as well, right? So now we're going to talk a little bit about the health literacy piece, just switching gears. And then according to the Institute of Medicine, the health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services that are needed to make appropriate health decisions. And so one of the things to remember now is that the Institute of Medicine is now named as the National Academy of Sciences. So when we're looking for these resources, this is what we should be looking at. And another thing to remember, although this is the definition that is being used within the strategy, the National Academy of Sciences, Engineering, and Medicine, under which the Health Literacy Roundtable falls, is also adapting a definition to address the definition of health literacy as well, because the arrow does point both ways, yes? Individuals have the capacity to obtain, process, and understand basic health information. The other arrow, if you will, is how is that provider presenting the information to the individual so that they are able to process and obtain this basic health information, right? So two of the resources that we are using are the National Standards for Culturally and Linguistically Appropriate Services in Healthcare. And these are this is a document that is available at no cost through the website Think Cultural Health. This is the updated version. The original version of the class standards was published in 2000. This one was recently published, or more so recently, in April 2013. The biggest change here is that it starts with the principal standard, which addresses the leadership within the organizations, because as we know, if we don't have buy-in from leadership, then the rest of the steps can be a little bit more challenging to navigate to accomplish that win-win. And then when we're looking at the 10 attributes of health, this is also a resource to talk about how to have certain strategies so that the organization is more health literate and also partners with the community. So these are two pieces that will be of interest to the organization. And also, too, there's some resources, right? There's also some resources for folks so that we're not reinventing the wheel, okay? So here's an example of effective communication when we add that cultural and linguistic layer to it. So I'm interpreting on one of the intensive care units where a patient has been heavily sedated so that more so to keep him safe, and because of some comorbidity issues. So the patient's sister comes in, and she has been providing some history to this very, very experienced nurse in the intensive care unit. And so we get to the point where the nurse asks the sister, and this is a middle-aged Latino male with comorbidity issues, and the patient, you get to the point where after the staff talks to you and everything, they ask you, well, do you have any questions? And the patient's sister asks, why are his hands so swollen, right? Because he has an IV through one of his hands. And I interpret that, and the nurse responds, well, it's a physiological explanation. And I interpret that. And taking into consideration that this is emotional, anytime that we have a loved one or we ourselves are not feeling 100%, we're a different person. And to see a loved one in an ICU unit with all the apparatus that goes along with being in the ICU, this was the response. Well, it's a physiological explanation. Now, to those of us who are in the healthcare field, we could understand this, assuming this is not our loved one in that bed and in that unit with this diagnosis. And so there's a pause because as an interpreter, there's nothing else being said, so there's nothing for me to interpret. The next sentence is the ICU RN is looking at me and then at this family member, and she says, that's the only explanation I have. So as an interpreter, there's various roles that I navigate through as I'm interpreting. And here is an issue of this very experienced provider providing an explanation where the energy in the room has now shifted and this family member is looks frustrated. And so I, as an interpreter, step out of my conduit role, which is, processing information from language to the other, and I present to the nurse, as interpreter, is there anything else you'd like me to interpret to the family, such as, is there anything else they have a question regarding your explanation? Because now it's an issue of saving face, yes. This provider is very experienced. However, that might not be the family member's interpretation of this. So the nurse says, looking at the family member, well, did you understand that? And I interpret that. And the patient's sister says, no, I don't know what that means. Okay. So now we've broken it down because the response was appropriate. Well, it's a physiological explanation. However, if we're adding the cultural and linguistic layer to health literacy, this has now not been a good outcome, yes? So instead of this family member walking away thinking this hospital doesn't know what it's doing or this provider is inept, neither of which is the case, we are able to broker this so that there is more of a clear and effective explanation, right? And so now some of the policies that are in place. It's the Affordable Care Act. One key to effectiveness and success of the exchanges, right? Because now we're talking about the health exchanges, which are very present in the work that we do. It's going to be the ability of consumers to understand and navigate the process of choosing plans and becoming insured. So now the Affordable Care Act takes the cultural and linguistic competence piece into consideration as well. So with the ACA, there is information regarding the provision of the class standards and the work of the class standards more so within the ACA, and that will be one of the resources that we provide to folks as well. So you know where these resources are, and then are able to review them as well, right? The federal mandate regarding language access is Title VI of the Civil Rights Act of 1964, and that prohibits exclusion from participation in or denial benefits of any resource that receives federally, that is federally funded. So, for example, an example of a civil rights violation would be looking at someone and understanding that they need an interpreter and saying something like, oh, come back when you bring an interpreter with you, or saying something like, you don't need an interpreter, right? Or saying, oh, you know, can you bring someone with you? Or, you know, back in the day, hopefully it's not being done anymore, or not as often, is the overhead page of, and I'll use my language pairs as an example, you know, the overhead page of, if somebody speaks Spanish, can you please come to the emergency room? You know, that's a civil rights violation. Or, you know, again, the shout out in the waiting room, does anybody here speak Spanish? You know, that kind of thing. These are all violations, and violations can be reported anonymously. So if somebody were to observe this happening, it is within their right to report this violation anonymously. And then the American with Disabilities Act, this is the act that supports the provision of sign language interpreters for services for our deaf and hard of hearing communities. And then also, as I was interpreting recently, and a provider had said to me, oh, I'm so glad that you're here. We usually don't have an interpreter in the room. We have to use the phone. And there are pluses and challenges to using telephonic interpreting, and that's a whole other workshop. However, his response was, we usually have those interpreters that use their hands, and I'm, you know, just thinking, okay, so this is a teaching moment. And I said, so that's a sign language interpreter, yes? And he said, oh, yes, yes, yes. You know, and again, you know, this is a teaching moment. Individuals are open to learning about the different terminologies and the use of services for language access and cultural competency, and these are opportunities to provide that information and to provide accurate information. And so, as Tony Robbins says, you know, to effectively communicate, we must realize that we are all different in the way we perceive the world and use this as a guide to our communication with others. So going back to Anais Nin's quote, you know, we don't see things as they are. We see things as we are. We walk into a world with our lens, because that's who we are, yes? And so looking at the resources that DISRIP is going to be providing throughout this process, you know, is really, really going to be helpful, and knowing who to reach out to within your organizations or the organization in general is also going to be key. And my understanding is that this information is being communicated so that we are all working smarter and not harder, yes? And remembering that this is a journey, and we can change the climate. You know, when somebody says to me that they are completely culturally competent, I pause, because there's so much to learn. There's always so much to learn. And that's one of the fabulous things about working in the environment in which we do work in, right? So I'm just going to turn this over to Minji just for some next steps, and then there are some resources that I'm going to walk through as well.
Yeah, sure. The next steps, so we do have our active committees, the Cultural Competency and Health Literacy Committee. The membership is always open, so if you have any interest in getting involved in that committee activities, please feel free to email me. And also, as Wilma has mentioned, we do have the champion meetings continuing quarterly, and we're going to have increased activities in terms of implementing and bringing back the information to your organization. So all those champions should have received the invitation for the next meeting. If you haven't, please feel free to email me.
Okay. And so here are just some links very quickly, and you'll have access to these as well. That's the Patient Protection and Affordable Care Act, which is the full name of the ACA, as we know, right? And then Section 1557 of the PTACA, this talks about the cultural and linguistic relevance within the Affordable Care Act, and also makes reference to data collection. So keeping in mind that more of the policies are being woven throughout each other, yes, to support these initiatives. In the American with Disabilities Act, the U.S. Department of Health of Human Services Office for Civil Rights, Title VI, for additional information regarding cultural competency and language access and health literacy. Here is the Institute of Medicine's 10 attributes of a literate healthcare organization. And also this document is very helpful to look at some not only lessons learned, but some possible next steps, so that we're not reinventing the wheel, but maybe refashioning a couple of the spokes, yes, because each of our organizations have their own culture as well. And then here's the link to the National Academies of Sciences, Engineering, and Medicine, the Health Literacy Roundtable, which provides a lot of information as well. So again, for the health literacy efforts, we are not reinventing the wheel again, right? And then for the class standards, this is the next link. And remembering that the class standards are provided in 5 different languages and are available on this link also. And the Think Cultural Health website as well, which has many, many resources regarding cultural competence, language access. There are videos, there are training tools, and so that, again, these are readily available for your use at your discretion. And then the Institute for Healthcare Advancement does a lot of work regarding health literacy, and they also have a listserv that is free for individuals to join, and all you need to do is sign up. I'm not promoting any of these nor have any other than being on the National Academy of Sciences Health Literacy Roundtable, and also on the Class Standards Advisory Board. Other than that, there is nothing to disclose as far as, benefit or anything like this. But looking at these resources, we've paid for them already on April 15th. They are here for us to use. And then may have some requirements regarding signing on and participation in that. But I strongly encourage you to explore these as you continue your journey regarding health literacy, language access, and cultural competence. These are some resources that are focusing more regarding spoken and sign language interpreters, so our Code of Ethics, the American Translators Association, the 3 different types of certification for healthcare interpreters at the national level. New York State does not have a certification for healthcare interpreters. So there are national certifications for healthcare interpreters, keeping in mind that the certifications are not available in all languages. And then the Registry of Interpreters for the Deaf as well, which these are the 3 main certifications for languages for you to keep in mind. All right. And then I turn this over to Minji for our questions.
All right. So just to remind everyone that please remember to email the district email with your organization name, the attendee's name, their job title, and their email addresses. And after this webinar, you'll receive a link for the post-training assessment and the course evaluation, as well as the slide set as well. Let's see if we have any questions so far. We'll pause for a little bit until we gather some questions. Thank you.
For beta.
Okay. Okay, so we do see a couple of hands raised. If you can, please put it in the chat box and we'll be able to answer that question. And also this webinar is recorded, so we'll be able to share that recording if you have others in your organization who would like to watch it in the future. Yeah, I see a lot of raised hands. Please feel free to email us in this email or put in the chat box. Thank you. Okay, so we have a couple of questions in the chat. Let's see. We have the first question related to whether district funds will pay for the interpreter services. Since the district cannot provide duplicative funding that is already reimbursed, unfortunately, interpreter services will not be funded through district, although we will explore other options in terms of if there is any barriers related to current interpreter services, we'll explore that option.
We have a question involving, that mentions involving clients from different cultures and helping develop some of the materials, and then how will they be selected? So I'm interpreting this question as the organization is involving clients from different cultures to develop some of the training materials, and I think this is a wonderful idea. And how will they be selected? Now, if the question means how will the individuals that will be helping the training materials be selected, that's one question. And how will the, versus how will the training materials be selected? Yes, that's a separate question. So for example, whenever we're developing any training materials, we know best what we would like that individual to walk away with, yes? And so, one of the things would be, and this is just, you know, just very, very basic, is how would you approach this if this were English to English, yes? So you're developing a training material. There's certain things that you really, really want to make sure come across, whatever your objectives are and whatever your action steps are to be able to be successful, have your client be successful. And so once that first development has been completed by the organization, because this is a very regulated environment and we have to be sure sometimes to include certain things, whether or not the community might think they're relevant. And then once that information and that, let's call it first draft, has been developed, then either presenting it through a focus group or requesting individuals that you feel will feel comfortable responding to that would be very helpful. And also asking the staff what their thoughts are regarding the development of these materials. So, for example, as a former manager for a pediatric subspecialty facility in the Midwest, prior to moving to Albany, we were asked to translate part of the discharge packet, and that for a the neonatal intensive care unit, and we were asked to translate it into Spanish. So one of the things that we did was we had the final teaching material, and we ran it past 2 interpreters who are very strong translators as well, right? Because some of us have strong oral skills, some of us have strong written skills. Usually hospital-based interpreters have to have both, okay? And so what we did was, with the first draft, we ran it past the Spanish interpreters, which came from various Latin American countries. So we had someone from Colombia, Mexico, Puerto Rico, Dominican Republic, Guatemala, and Argentina. Once we got to a point where there was agreement with the terminology and the presentation, we then presented it to some families and asked them, so what do you think? We're trying to make sure that this is going to be helpful. What do you think is helpful? And so we were able to get buy-in that way. So it's a process, because sometimes even though we create a document, there might be those who are actually the end user of the document within the organization that think, you know what, this isn't, it's nice that in my language fair that it's in Spanish, but it's not going to resonate with this community. And so in making sure we have that lens, and then being able to identify some individuals which we think might be open to providing some feedback is also helpful. So then you get to the point that you feel comfortable that the document you are providing is helpful to not only your organization, but to the individuals and groups who will be the recipient of that information.
Okay, so the next question I see is that is there a cultural competency training that we could bring on site to organizations so that would meet the required metric? So in phase 2, we will be continuing with the training activities related to cultural competency and health literacy, and we will be disseminating the survey that's related to cultural competency, and that would mention about the training activities that's happening at your site and what trainings that might be most valuable for your organization so that it's tailored to your organization. So yes, it will be based on your organization's need and what's currently available, and based on that, you will meet certain metrics and that would fulfill the requirement for the district.
About the technology.
So we have a question about people who are becoming more technologically disadvantaged with patient portals and health information being electronic and test and patient records that are found only there and accessible through those portals. And that includes test results. So how it's so necessary to continue to share these methods, but how are individuals going to be able to learn how to access these, this information via technology? So this is quite the health literacy question because there are individuals who consider themselves very technologically savvy and aren't. There are those who consider themselves to not be technologically savvy and are. And then there are folks who quite honestly are technologically savvy, and then those who are not for whatever reason, yes? And so this response is, I think, can be answered on a few different levels. One is, what is the organization doing to be able to prepare that individual to access that information? If this is the only way that they're going to be able to get this information, is there an opportunity to sit down with that individual and do kind of a mock-up to show them how they'll be able to access the information is one. Another is asking the individual, is this their preferred way to receive information Or is there another way that the organization can provide the information? Some folks really appreciate that phone call back, you know, being told that lab results are A-okay. Or is there an opportunity to find a win-win if this is the only way that information can be shared? So it's much more on the level of partnering with that individual and communities to be able to find out how would they be able to get this information in a way that will be beneficial to not only the individual and also the organization. Okay. We're being asked if there are resources in the Albany area regarding sign language interpreters for primary care offices or getting handouts in Braille for the blind. Yes, I am aware of an organization, unfortunately, that the name slips my mind. As a matter of fact, I just met this individual earlier this week. I'm more than happy to provide that information to Minji to be shared with the group as well. The other thing is regarding sign language interpreters, if you go to the website for the Registry of Interpreters for the Deaf and put in your area regarding a certified sign language interpreter, that's another resource since they do have a database for sign language interpreters in various areas throughout the U.S. Yeah. So there's a question, a follow-up question to regarding the provision of reimbursement for language access services. And so, for example, and again, I don't want to speak in regarding an area where it's where there are those who are much more versed than I am in this. However, my understanding of how the reimbursement for spoken language and sign language interpreters is in New York State. New York State is one of 13, including Washington, D.C., which provide reimbursement for interpreting services, and that's across the U.S. And other states do receive reimbursement for translation services. Now, the reimbursement across the states varies, and so it is our understanding that in New York State, there is reimbursement for interpreting services that are when services are provided in certain areas. So, for example, my understanding that the interpreting services is reimbursed for emergency room use, but once that patient hits the unit or is admitted, that reimbursement is no longer possible. Now, we can provide information on where you can explore this a little bit more, and apologies to those who are much more versed in this than we are here. One of the comments when this had been brought up in a previous discussion with DISRIP was that since there is already this level of reimbursement for interpreting services, regardless of where that service takes place, DISRIP monies are not able to be utilized in addition to. And we're not saying in place of, but in addition to. So since there currently exists a level of reimbursement for interpreting services, because of that level, regardless of where and who and how that reimbursement takes place, DISRIP monies are not able to cover or be part of that reimbursement process as well. At least that's my understanding from previous discussions, and I am more than happy to be corrected if I have misspoken, and if there are others who are participating who have more up-to-date information and who can also provide clarification.
Okay, we'll give a few more minutes until we wrap up the webinar. We'll wait and see if there's any other last-minute questions. All right, we don't see any additional questions, so we really thank your time, and hopefully this presentation was really helpful for you, and thanks, Wilma, for a great presentation. And please look forward to the email for post-training assessment and course evaluation, as well as the slide set. And if you have any questions, please feel free to email us or call us, and I hope you have a great day. Thank you.